have in place to address hypertension. Now, American women were chosen as the target population of this project because of some unique risk factors that many of us have that increase with age, and also because of our busy schedules. We're some busy people, aren't we? A lot of us are going to school, we're raising families, we're working either full-time or part-time jobs. Some of us have other family members that we help take care of. We have grandparents and sometimes elderly parents. And what else do we do? Some of us go to church on Sundays. We have cultural activities we attend to. Cinco de Mayo, 4th of July is always something, right? And then we also have just regular events in our lives that we go. So it's easy to see with so much in our schedules, many of us don't pay enough attention to our own health needs, right? They tend to go on the back burner, and especially blood pressure, because blood pressure does not have bells and whistles, and we don't see it in the mirror every day. So a lot of us really don't pay quite enough attention to it. Now, these are some statistics on hypertension, and this is as of just a few months ago. In 2015, 1 in 3 adults in the United States have hypertension, and about 52% of them do not have it under control. That means there's people walking among us with blood pressures of 140 over 90, or maybe even more than that, and little to no effort is being made to bring those numbers down. Or efforts are being made, but they're not working. The numbers are not coming down. The United States spends about $46 billion every year on hypertension. That's between the cost of treatment for hypertension, treatment for complications from hypertension, because it's not just high blood pressure, it affects our eyesight, our heart, our kidneys, and also the cost, loss of productivity when people can't go to work because they have hypertensive crisis. There's a lot of money being spent on this, and it's preventable. Now, in addition to that, hypertension is a risk factor for 2 of the leading causes of death in the United States, and those are stroke and heart disease. Women have a higher rate of stroke than men do, and heart disease is a leading cause of death for both men and women. And women also have some other unique risk factors. Pregnancy-induced hypertension, this is a transient spike in blood pressure. It occurs when a woman is pregnant. And even though the blood pressure normalizes after the baby is born, these women remain at a higher risk of developing hypertension later on in life compared to women who do not experience pregnancy-induced hypertension. Using birth control pills, this increases a woman's risk of developing hypertension. And a woman who smokes and takes birth control pills has an even greater risk of developing hypertension. And then I want to talk about this last one, because this is largely related to estrogen. As estrogen levels diminish with age, the risk of developing hypertension and having a stroke, because remember, hypertension is a risk factor for stroke, increases. Estrogen comes down, risk factors increase. Well, the problem is estrogen is a hormone. It's not on a time clock. When we turn 65, it doesn't say, okay, I'm done, I'm leaving now. It doesn't work that way, right? Women can start to experience a diminution in estrogen levels in their late 40s to early 50s. So we don't want women to wait until they're 65 to start thinking about their blood pressure. You know, we don't want our young women to think, oh, I have years before I have to worry about that. We want them to start monitoring now and take steps to either keep their blood pressure normal or take steps to reduce those numbers if that's what they need to do. 65 is not a magic number. So this is my PICO question. Anybody have a hard time with their PICO question? Yes. I have classmates who were still complaining about their PICO questions. I think this may be something that's going to haunt some of us. I had this idea in my head that these automated devices, and we're going to be using these a little later on in the presentation, may have the same effect as the bathroom scale. You know, we walk in the bathroom, we see the scale, we think of our weight, right? Most of us know what we weigh. We have some idea. And most of us make some effort. You know, we eat a few salads, we exercise, right? We make some effort. I thought these might have the same effect, just act as a reminder. So I had to put that idea into a PICO question, and I had to put a time at the end because I only had 4 months to get it done. So let's take a look at mine. My population is American women between the ages of 30 and 55. The intervention is home blood pressure monitoring. It's compared to routine screening in a doctor's office. The outcome is a change in blood pressure, and the time frame was, well, 3 months, because I had to have a month to come up with the PICO, and I had to have time to do some preliminary research. So yes, this is very important. If you haven't already developed your PICO question, try to get that nailed down. It's a large part of it. And try to pick something that you're interested in, something that you really feel passionate about. That'll help. This is the exhaustive literature review, which started the whole thing, and this was done in an effort to find evidence-based guidelines for home blood pressure monitoring and for some research to see what's known about home blood pressure monitoring. You know, in healthcare, we don't use interventions because we just think it might be a good idea. We use them because evidence has shown that they're effective, and that's the best way to do it. So these limitations were placed to narrow the topic to home blood pressure monitoring as opposed to just hypertension in general, because we would have thousands and thousands of articles. And the keywords were used both in singularly and in combination. So unfortunately, guidelines for home blood pressure monitoring have not been established yet. We don't have those. However, the Emergency Nurse Association has developed guidelines for the use of automated blood pressure devices. And even though these were originally intended for use in a clinical setting, they have become the primary tool that's used in private homes for monitoring blood pressure. So they're applicable. We can use those guidelines. Let's see. Now, I want you to notice the levels A, B, C. These are based on the Melick and Feinholt Overholt level of evidence scale. Is everyone familiar with that? Has everyone seen that? Let's see. Oh, and also notice the very first one, appropriate for use in adult populations. That was relevant to the PICO question because we're looking at adult women. And also this one, the placement of the cup and regarding sleeves. So this is the scale, and this is in the research evidence book. Has everyone seen this scale? So level 1, evidence from a systemic review and meta-analysis of all randomized controlled trials. That's the highest level of evidence that's applicable to an intervention, such as home blood pressure monitoring. The first article that was chosen to go on the capstone was a study by Aguar et al. And the purpose of this study was to review and quantify the magnimum effect of home blood pressure monitoring. So they wanted to know how substantial the relationship was between home blood pressure monitoring and a change in blood pressure. It was a systemic review and meta-analysis combined, so it meets the criteria for level of evidence 1 on our favorite scale. And the relevance to the PICO was just the design of this study. Automated devices were part of the inclusion criteria. The study participants were comparable in age to that of the target population in the PICO. And the randomized controlled studies all took place in the United States. And these were the results of that study. And you can say that they did see there was a reduction in both systolic and diastolic blood pressure. And it was not a significant reduction, but the PICO only wanted a change in blood pressure, so we have that. The study also reported heterogeneity, and that means that the randomized controlled trials were not identical. There were some differences between those trials. Some of the differences were reported as the definition of blood pressure. Some trials reported it as a daytime average. Other trials reported it as a 24-hour average. And also the clinical setting where the control group had their blood pressures taken. Some of these used a local community health clinic and others did it in a hospital. Changes like this have to be reported because we have to know if there's any possibility that they affected the results, and if they did, how much they affected the results. And to demonstrate that, they implement what's known as a random effects model. A random effects model seeks to report the average effect of an intervention within a group, whereas a fixed model reports the best estimate of the effect of the intervention. models are considered more reliable. However, when we know that there's differences in those randomized controlled trials, the random effects model is widely accepted in research. And what's the significance? Why would this be included in something as important as the capstone? Because the numbers weren't really significant. It wasn't very much. But it does give us a basis for further research. These study developers did an exhaustive literature review. They did have some results. The references can be pulled out and they can be used to research further.